Hello everyone, welcome at SudhirEyeCoach, a channel for emerging and budding ophthalmologists. I am Dr. Sudhir Srivastava, Cataract and Refractive Surgeon, Head of Sanai Group of Eye Hospitals at Lucknow. Today I'll be sharing a video of a routine case during which a posterior capsular rent occurred. These things can happen unexpectedly and at times we may not even know the exact reason. It was a normal looking case with a pristine clear cornea. The patient had a grade 2 nuclear cataract, and performing phacoemulsification in such cases is generally not very challenging and often quite rewarding for the surgeon, and it appears treat to a surgeon. So I was doing this surgery under topical anesthesia, and normally I create two side port incision and one clear corneal 2.2 mm of incision. I did capsular access through the side port incision, then I did hydro procedures, and hydro dissection and dilation has been done. A well-sized capsular access and a neatly separated grade 2 or 3 nucleus are very satisfying for a phaco surgeon. This is an unedited video. Now I am ready to start the phaco fragmentation, and normally I use Sinsky hook as a second instrument. Always remove the epinuclear plate over the nucleus, make the nucleus naked, and then whatever technique you are comfortable, you can start phaco fragmentation. Normally I do hold and split technique, where I just hold the nucleus with the phaco tip, and with the second instrument using as a fulcrum I split the nucleus fragments in the pieces. What you can call, it's a kind of vertical chop technique. Now under epinuclear plate settings, removal setting of the phaco fragmentation, I removed the epinuclear plate. Probably this time I rotated the epinuclear plate probably more firmly, and that has created a big size rent. You can see a big size rent where the edges are not visible, and this is a kind of situation that can be very depressing for a surgeon. In an otherwise routine case where you have created a large well-centered capsular axis, encountering a complication is unexpected. The challenge now is to remove the remaining cortical matter safely and proceed with IOL implantation. It is always more satisfying if we can still place the lens in the bag, allowing us to consider this patient as a normal post-operative case. Fortunately, in this situation, there was no need for any kind of vitrectomy at this level. This is the moment where we must control our nerves and avoid panicking. Take a pause, plan your strategy, and proceed step by step. Always refill the antechamber with viscoelastics to maintain the space and provide a tamponade effect so that the vitreous doesn't move forward. Fortunately, there was no vitreous displacement, so I decided to reduce the bottle height and or the reduced intraocular pressure settings to the minimum, and with the visco tamponade technique and gradually with the dry aspiration, I started removing the cortical matter, and successfully I removed a chunk of cortical matter which is quite away from the rent. Always prefer the cortical remover first, which is far from the rent. Since now I am working in the area of rent, so I used the second instrument, and I used visco ejection along with the irrigation just to maintain the tamponade over the vitreous, so that we can keep the vitreous phase intact and there should not be any vitreous movement forward. Now before removing the irrigation aspiration tip, I filled again the antechamber with viscoelastics, and now the time for IOL implantation. So because I was able to locate the bags even in the two parts, so I decided to go with the in the bag implantation. If you are not sure about implanting the lens in the bag, then you should go with the multi-piece lenses, because single piece lens is quite thick, and in the long run it can give chronic uveitis and glaucoma. In the end, it was very reassuring, because despite the large rent, I was able to remove all the cortical matter and implant the lens securely in the bag, and it was well centered, and the patient was very happy very next day. Sometimes the date simply doesn't go your way, and as a routine case can certainly turn into a challenge, but what truly matters is how you manage the situation and how you come out of a complication. If you are operating, complications are part of surgical life. They will happen. The mark of a good surgeon is not to absence of complications, but how you calmly and skillfully you handle them. So enjoy the video and just watch the steps carefully, and if you have any suggestion, comment, please do so. And if you are not subscribed my channel yet, please subscribe my channel. It gives a lot of encouragement, and it gives an aim to create videos. Thanks for watching.